I'd like to introduce Dr. Dean Ruether. Dr. Ruether is a medical oncologist working in the Tom Baker Cancer Center and is the provincial leader of the GU tumor program and has an appointment as assistant professor with the University of Calgary. Since 1995, he has been involved in the care of patients with prostate cancer and other genitourinary malignancies. His work outside of clinical care of patients includes clinical research trials with GU cancer, teaching medical students, residents, and trainees with oncology training programs. The GU program in Calgary under Dr. Ruether's leadership has been involved in clinical trials that have seen significant improvement in the treatment options for men with advanced prostate cancer. Dr. Ruether is also involved in educational initiatives designed to improve how we communicate with patients newly diagnosed with prostate cancer about their disease and about their disease and treatment options. I lost it there for a second. Anyways, I'd like you to turn the microphone over to Dean, Dr. Dean Ruether, and let you carry on.
Thank you very much. So I'm delighted to be here this evening to have an opportunity to share some new information with you. I had the pleasure of speaking to your group last year around this time, and I'm pleased to tell you that although things do move slowly within the ways that we care for patients with cancer, we have seen some significant improvements over the last year, some new opportunities, new treatments for men with prostate cancer, and new information that I think is important for men to be aware of in terms of decision-making around early-stage prostate cancer. And so those are some of the things I'm going to share with you tonight, and I'm happy to take questions either during the course of my talk or at the end. So I'm going to talk with you a little bit about some of the things I talked to you about last year and let you know where I think we've made some progress. I'm going to share with you some information about some of the programs we offer here in Calgary for men and their families who are dealing with prostate cancer. Some of that may be things that you are aware of, but some of it may be new information. As I said, I'm going to talk to you about some important developments over the last year and things that I think are important for men dealing with this diagnosis to know and understand. And as I said, I'm happy to take questions at any time. So let's start with the issue of prostate cancer screening. This remains within medicine a controversial issue. There are recent publications around large clinical trials that continue to debate the pros and cons of what we would call mass screening for prostate cancer. As yet, there is no recommendations for a mass screening program, similar to what you might be familiar with, say, breast cancer, where in certain age groups and in certain patients with a risk for breast cancer, we encourage mammography be done on a regular basis. It's not yet clear that that kind of mass screening is going to be beneficial in terms of early diagnosis of prostate cancer, but there is support for what I call individualized screening. So for a man who particularly has a family history of this disease, it's quite reasonable and appropriate to be having a discussion with your family doctor about the pros and cons of prostate cancer screening, meaning digital rectal examinations and PSA testing. I think with more time we will see sufficient evidence to tell us that screening for this disease does have an impact when you look at large populations of men, but we're not there yet. We still know we overtreat a lot of men with localized prostate cancer, and we cause a lot of problems in terms of bladder difficulties, bowel problems, effects on sexual function, and the impact that has potentially on interpersonal relations. So we'd like to do better in terms of selecting patients who need to be screened, and in patients in whom we identify the disease, advise them appropriately where they need to be treated or where they could potentially watch this problem and not pursue treatment immediately. We're getting closer, and I think over the next few years we're going to see information about other tests that could be done other than PSA testing or in addition to PSA testing that will improve our ability to use screening more effectively. I am happy to say, though, that PSA testing is now covered throughout the province of Alberta. It was not covered as a screening tool for prostate cancer when I last spoke to this group a year ago, but now, regardless of the indication, that test is covered by Alberta Health Services. So I think in that sense we have made some progress. I want to talk to you, yep.
Would one of those tests be the PCA3 test?
Potentially, that's one. But there are other tests that can be done on blood, potentially also on urine, that might help us to select the patients who are at higher risk for progression of disease.
Is there any way of getting a PCA3 test?
You can get it done. You have to pay for it yourself. And last I checked, it's about $300. But it is possible to get it done.
Yeah. Within the province?
I don't think the test is done in the province. I think it's sent out. Yeah. Any other questions about that? Okay. Many of you would be familiar with what's called the Southern Alberta Institute of Urology. This is the facilities that were built by the urologists in Calgary here and are located on the top of the new parkade that sits east of the just east of the main entrance to the Rocky View Hospital. So about half of the 6th floor of that building is taken up by the SAIU. That means that for the last almost 2 years, all of the urologists who work in Calgary, and there are now 17 of them, have their office space in that building. It's adjacent to the Rocky View Hospital where urologic services are based. And having that concentrated expertise in one area has created the opportunity to build programs that provide support not only to patients with prostate cancer, but patients dealing with bladder cancer, dealing with the complications of treatments of urologic malignancies. And it's also created the opportunity for us to collaborate more effectively in terms of research projects and learning. So this has been a huge development for us here in Calgary, and it's to the credit of my colleagues in urology who pushed for this and raised the money for it. The facilities are built on Alberta Health Services land, but Alberta Health Services did not put up any of the money for the construction of this facility. That was all done through raising donations from private donors. And so, as I said, a huge credit to the urologists for their ongoing effort to develop this and build it. In the last year, we have recruited 3 new urologists to the city. That was desperately needed. As I'm sure many of you know, trying to get in to see a urologist is not an easy thing to do. And we recognized for a long time that there weren't enough of them. So in the last last year, we've had Dr. Jeff Gatto and Dr. Eric Heinemann join us. They are both adult urologists. And then we've added a third pediatric urologist, Dr. Bryce Weber. So that has expanded our ability to provide the appropriate care for patients, adults dealing with genitourinary malignancies, but also much needed support to the pediatric program, as there were only 2 pediatric urologists in the city prior to that. And again, a situation that was in desperate need of attention. Little update about what's happened with cancer facilities in the province. So last year when I presented to this group, I told you about developments at the what's now called the Jack 80 Cancer Center in Lethbridge. As of mid-2010, there was 1 radiation oncologist at that site, and so patients living in the southern part of the province with prostate cancer could undergo radiation treatment closer to home. They didn't have to come to Calgary for external beam radiation. Over the last year, we've recruited a 2nd radiation oncologist to that site, so there are now 2 of them, and there are 2 medical oncologists, people who do what I do, use drug treatments to manage these diseases, have been on site in Lethbridge since September of this year. And so that has significantly improved the kinds of services we can offer to patients in the southern part of the province, and means hopefully less travel for people back and forth to larger centers like Calgary and Edmonton. Construction is underway for similar facilities in Red Deer. So the cancer facilities in Red Deer are getting a significant upgrade, and we hope to be able to start offering radiation treatment to patients there in the fall of 2013. And over the next year to 2 years, we will be looking to recruit a couple of radiation oncologists, and then following that, medical oncology services to that site. It's not as certain as in terms of what's going to happen in Grand Prairie. The original plans with the development of what's called the radiation therapy corridor, so these were the plans to develop radiation facilities in Lethbridge, Red Deer, and Grand Prairie to supplement what's available in Calgary and Edmonton. The plans for Grand Prairie are not quite as certain as yet. We were originally operating under the assumption that we would have facilities there for 2015. That's probably pushed back a bit, probably going to be more like 2017 before we've got full capacity to give radiation treatment there. But those plans are underway. No progress yet in terms of actual construction. They're still in the design phase of the planning and trying to figure out how to incorporate these facilities into the new hospital that's being built up there. We've been waiting for a long time in Calgary for word about new cancer facilities here. As some of you may know, we're presently divided. We operate out of the Tom Baker Cancer Clinic and the Holy Cross. And moving some of our operation down to the Holy Cross has helped us to deal with space crunches over the last few years, but it's not in the best interest of patient care for our facilities to be divided, and it's certainly not convenient for the docs and nurses who are involved in the program. So we've been waiting for a long time to hear about new facilities in Calgary, and I've stopped holding my breath. We'll see we'll hear when we hear. We desperately need more space, there's no question, and we can't expand on our existing site at the Tom Baker sufficiently to meet the needs, so we need a new facility. So maybe next year I'll be able to tell you more about that.
Is that a matter of space, or is that a matter of equipment going into space?
It's space. Yeah, it's space. Staff will be an issue too, but right now we've recruited a new medical oncologist to join us in December, and we have no place to put an office for him, and we don't know where he's going to do clinics. So it's space, and that has been our problem since about 2004, actually. So. I'm going to talk to you a little bit now about what we call the Rapid Access Program. Many of you may be familiar with various components of this program. The Rapid Access 1 is the program and process that was set up by the urologists to deal with the need for more expedient referral for a man who has a concern, either an abnormal digital rectal exam or an elevated PSA, recognizing that that man needs to be seen by a urologist to facilitate an assessment and biopsy and coming to a diagnosis if prostate cancer is the issue. The Rapid Access 1 program has been operating now since about 2004 and has done a lot to expedite that process and get our wait times in regards to dealing with those issues down to a few weeks. Beginning in 2007, we started what we call Rapid Access 2, which is an educational program that we hold about every 2 weeks for men who are newly diagnosed with prostate cancer and their families to come and hear about, sort of get the basics, the background about prostate cancer, what every man needs to understand about that disease, and then some information that is shared with the people who attend the session from the local experts, the urologists, radiation oncologists, medical oncologists, about the treatment options for localized prostate cancer. As I'm sure many of you are aware, there are a number of different options, and choice is a good thing, but it's also for patients sometimes very frustrating and anxiety provoking, because how do I know what to choose? How do I know and how do I get a better understanding of why my doctor is directing me to look at certain options? So we established this education program with the hopes of helping to address some of those questions. And since starting in October of 2007, we've put over 1,000 men through this education program. It has had added benefits in that it's also helped us to deal with our wait times and appropriate referrals up to the cancer clinic for consideration of radiation therapy, either by brachytherapy implantation or by external beam. So the impetus was to provide the education that patients need, but there have been added benefits that we hadn't anticipated from this program. We still are very keen to develop a video link to Lethbridge. We'd like to make this educational session available to patients in Lethbridge. The technology is not the challenge, it's having somebody on the other end who's willing to be there to bring patients into the room, sit there during the session with them, help address questions, that sort of thing. But we're continuing to work on this, and I hope by the time I come back to talk to you maybe next year, we will have this up and running and available to patients in Lethbridge. Eventually, we would like to make this available to patients throughout the province, but that's a more long-term goal. Rapid Access 3 is a newer program. If you had surgery for your prostate cancer up until year and a half ago or so, you would have gone back to see your urologist to have stitches removed, catheters taken out. Sometimes that was a challenge to get in. It's a challenge to get in to see the urologist an appropriate period of time following the surgery. And then we'd have patients who occasionally ran into problems and ended up having to go up to the emergency room to have issues dealt with after their surgery. So the Rapid Access 3 program is a coordinated program to provide the post-operative care that is needed. Louise Thompson, who some of you may know from the Prostate Cancer Center, is the nurse coordinator for that program and others that operate down there. And so now she sees all of the patients post-operatively, usually goes up and sees them on Unit 82 at the Rocky View immediately following their surgery to introduce herself and set up the follow-up visits that's needed. Patients come into the Southern Alberta Institute of Urology for follow-up to have catheters removed, staples taken out. And this has actually helped us to avoid sending patients up to the emergency room on occasion as well. So I think this has done a lot to improve what happens in terms of post-operative care, provide a consistent point of contact, and I think makes things easier for patients. Rapid Access 4 is what we call our Intimacy and Continence program. So we offer another monthly educational session called Life After Prostate Cancer, and that's a session that is attended by a clinical psychologist who is very familiar and comfortable dealing with the issues around sexual function and intimacy that treatment for prostate cancer can cause for a man and for his partner. There is a physiotherapist who attends that session who can teach men how to do Kegel exercises, a term that's probably more familiar to women in the room. Those are pelvic floor musculature exercises that can be used to try and help deal with issues related to continence and bladder control. And there's a dietitian who attends that session. Those sessions are held every month, and patients simply call the Prostate Cancer Center to register themselves. You don't need to be referred by your doctor. And we have patients come to this session prior to having their treatment to get an idea of what they may be dealing with afterwards. We have patients who come to these sessions a month or so, a few months after their treatment. We've had patients come to this 10 years after their treatment for prostate cancer who are dealing with these issues. The continence portion of that program is still a work in progress. I think you're going to be hearing from Dr. Richard Baverstock next month. He and one of his partners have set up another program within the Southern Alberta Institute of Urology called VESIA, and I won't steal his thunder, but I think you'll be very pleased to hear what he has to offer for patients who are dealing with issues related to bladder control, including men who've been treated for prostate cancer. And then finally, we offer now a couples workshop. Dr. John Robinson is the clinical psychologist who works with us, and they hold these workshops 4 times a year. This is to help couples who are dealing with the challenges that prostate cancer treatment can cause for intimate relationships. And the feedback we've had on those sessions is very positive. They're very helpful. And finally, Rapid Access 5, or what we call the Active Surveillance Program, is just getting underway. Most of our urologists have been offering active surveillance to the appropriate patients over the last few years, but it's done a little differently in each urologist's office. And there's a lot of discussion and debate in the medical community about how active surveillance should be done. Dr. Eric Heinemann, one of the new urologists that I mentioned earlier, has developed this program with the intention of harmonizing how we do active surveillance, but also creating the opportunity for us to develop, alongside the program that is providing clinical care, opportunities for research, so we can learn more about this disease and help to try to identify men who are good candidates for active surveillance and may be able to avoid dealing with the treatment issues related to prostate cancer, and separating them or differentiating them from the men who definitely will need treatment. So those clinics have just started operating, but I am very excited about what this program will offer to patients and what it will provide us the opportunity to learn over the next few years. So this is just a little bit more information about the intimacy program. Now I want to talk to you a little bit about specific information that has come out of clinical research trials and studies over the last year or so. And this is an important one. It's called the PIVOT trial. So this was a trial looking at active surveillance versus prostate cancer surgery for men with localized prostate cancer. I'm sure if you've done any reading about this disease or tried to educate yourself about it, you are probably aware of the term active surveillance. You're probably also aware that this is a relatively new option. We used to use, for men who we didn't feel were going to be appropriate candidates for treatment, an approach that we called watchful waiting, which meant we know you've got the disease. Curative intent treatment's probably not a good option at this point in time. If the cancer causes a problem, we will intervene. Active surveillance is different. It means that you're going to be followed and screened regularly for changes in how the disease is behaving, and the potential to intervene with an active treatment at such point as it's deemed appropriate to do that. There are a number of clinical trials that are trying to determine which men are appropriate candidates for active surveillance. And so this trial is now reporting over 10 years of follow-up. So 731 men were randomized between 1994 and 2002 to either surveillance and intervention at some point while they were being followed, if it was appropriate to do that, versus immediate surgery. And we had to follow patients for a long time to see whether there was a difference here. And what this trial is now reporting is that, and they looked at a number of different outcomes. The first and what we call the primary outcome was what happens to these men in terms of mortality related to prostate cancer or otherwise, so what we call all-cause mortality. And then secondarily, they looked at how often is prostate cancer the cause of death for men in these two treatment arms. And what the trial has showed us is that men who had immediate surgery were no less likely to die of any cause than men who had surgery or treatment delayed as a result of going on to active surveillance. There was a bit of difference, so men who were on the surveillance arm were a little more likely to die from prostate cancer. Men who were on the active treatment arm, so who had surgery up front, were a little more likely to die of other causes. But in the end, the balance in terms of the number of deaths was equal. And so what this says to me is that active surveillance is a viable option for many men. It is an option that still needs to be studied in the context of clinical trials. But with this kind of evidence, I'm increasingly comfortable for men, particularly with low-risk disease, that surveillance is a viable option.
So do both group of men have the same state of prostate cancer?
There was equal distribution between the two groups. That's the whole intention of doing a randomized study, is that you want to eliminate the potential for any biases. So there were, if you look at the two treatment arms, there was an equal distribution of the types of prostate cancer in those two arms. Yeah?
What was the mortality rate?
I'd have to go back and look at the actual numbers. Yeah, can't tell you exactly what that was. So as I said, I think this is a very important piece of information. It's not the definitive answer. And I think the two key pieces of information that come out of this study is that if you are a man with low risk, early stage prostate cancer, who is more than 65 years of age, if you are healthy and have a life expectancy of not more than 15 years, so if you have other problems with your health that would suggest it's unlikely you would live another 15 years, then observation is probably as effective in terms of managing your prostate cancer as going to immediate treatment.
What do they classify as low risk?
So that's disease that is confined to the prostate, Gleason 6 or less, so no higher than a Gleason 6, PSA of less than 10, and a small volume of cancer. So that's usually T1 up to what we would call T2B. And then for men with low risk, early stage, localized disease who are more than 65 years of age, if they have a life expectancy of more than 15 years, then this may be as good an option. Observation may be as good an option as surgery. Now, as I said, this is not the definitive answer for all men with prostate cancer, and this does not tell us that all men with prostate cancer are candidates for active surveillance. There are many men who need treatment. But there are a lot of men with low-risk disease who enter into treatment, and I think the benefits of that in terms of potential lives saved is questionable. And if we can spare men the toxicities and side effects that go along with treatment, then we need to look at opportunities to do that.
How does observation become management?
Well, if you're on an active surveillance program, then you're seen regularly for follow-up, and that's done in various ways. It might be visits every 3 months, every 6 months. PSA is repeated, and biopsies are repeated. And those biopsies are done anywhere as early as 6 months after the first set were done, as long as 18 months after the first sets were done. If things change, so if the rectal exam changes, the prostate gland felt normal and now feels abnormal. If a repeat biopsy shows that a Gleason 6 prostate cancer is now a Gleason 7, or if the PSA trends up over time, those are all things that would suggest that man might need to come off of active surveillance and go on to treatment.
How about checking to see if it has spread?
It's hard to do. A lot of those tests that we use, like CAT scans and bone scans, aren't particularly sensitive for picking up spread to other areas. If we're picking that up on scans, then we've probably missed the boat, missed the opportunity to treat a localized problem. So really we're relying on the results of the biopsies and the way the PSA is behaving to determine whether surveillance is an option. Sorry, I saw another question.
Dean, would I understand that Dr. Klotz look for a more final, definitive diagnostic to say that it's time to move on beyond active surveillance and that he relies on MRI for that determination?
I think MRI is potentially going to be helpful. It's certainly a better way of imaging the prostate than CT scans. I don't think we know yet where it's going to fit in terms of being part of an active surveillance program.
But he's pretty
I think he is, yeah. 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 Any other questions?
This research that Dr. Lewis is doing about the probability of a person going, they're looking at the genes or whatever it is, just recently into the university. How's that going to work with that active?
Well, I think the active surveillance program will create the opportunity for us to recruit patients to participate in the kinds of clinical trials that Dr. Lewis's work may inform. What we would like to find, what we would like to identify is a test either looking at a number of different genes that would identify a characteristic type of prostate cancer that we know is going to get someone into trouble. And that's the patient we should treat.
And isn't that what he's looking at?
That's part of what he's doing, yeah. But there may be other ways of detecting that. We can look potentially at gene signatures. We can look at something called metabolomics, where you look at proteins that are produced by some of these same genes, and you can measure those things in blood and urine, potentially in semen. So there are a number of different ways that you might try to identify a signature, either from the genes or within a blood test, that would help you to determine who's going to get into trouble and who's not. Any other questions about this? Okay. So as I said, this is not the definitive answer. I think it tells us that active surveillance is a viable option for some men. I think if you're less than 60 years of age, that's a person who probably has a longer life expectancy, and I'm not sure the results of the PIVOT trial are particularly helpful for that patient population. And most of the patients who were in this study were patients who had low-risk disease. If you look at the particulars of the trial and tease out the patients who had intermediate and high-risk disease, those patient numbers were fairly small. And I think we'd have to draw conclusions from this trial for those patients very, very cautiously. So I would not recommend an active surveillance program at this point in time for a man with intermediate risk prostate cancer, and certainly not for a man with high risk prostate cancer. But for men with low risk disease, I think it is an important question that patients should be asking of their doctors. Am I a candidate for surveillance?
Dr. Ruether, can you just remind us what the definition of low risk is?
So low risk would be a PSA of less than 10, a Gleason score of less than 6 or less, so no greater than 6, and a small amount of prostate cancer. And so that would include men with T1 A, B, and C disease and T2 A and B.
So what does that mean in terms of a report that comes back when the urologist says that you've got 10 cores, we examine 10 cores, and one has prostate cancer of such and such, or 3 cores of such and such, because that's how it's communicated back to us. We don't hear T1, 2, 3, we hear cores.
Well, you should be hearing T1, 2, 3. The number of cores that are involved does enter into the discussion from the urologist's perspective in terms of where their comfort level is for offering surveillance. So for a man who had 1 core out of 10 that had 5% of that core involving prostate cancer and has all of the features that I've suggested, go with low risk, so Gleason 6 or less, PSA less than 10, small volume disease in the gland, that patient would be a good candidate for active surveillance. I think many of our urologists would be very uncomfortable if a man has those features but has prostate cancer in 8 out of 10 cores. So the number of cores is going to impact the decision and the discussion about whether active surveillance is an appropriate option. But I think the place to start is, if I'm in the low risk category, so with all three of those features, am I a candidate for active surveillance? And if not, help me understand why. And that's where the conversation about the number of cores may come in.
Question, I heard a number of yes, yes, yes. We interpret or hear cores, and we hear percentages in that core. And
Right.
you can convey that back to your colleagues and try to figure out how to improve the communication in that regard.
It's always tough educating surgeons, but I'll take it under advisement.
We do listen to cores.
Do PSAs actually indicate things of magnitude? Like, some people believe them, some people don't.
Well, I don't think it's a matter of believing it or not believing it. First of all, PSA is not a specific test for prostate cancer. Other things can cause an elevation in your PSA, and that's part of the problem with using PSA as a screening test. Your PSA can be elevated if you have an infection in the prostate gland. It would be elevated after having biopsies done. So there are, if you have benign enlargement of the prostate, which most men experience as they get older, that elevates your PSA. So it's not a specific test for cancer. If the PSA is elevated, one of the questions that needs to be asked is, could this be related to cancer? And the only way to be definitive about that is a biopsy. But if your PSA is 30 or 40 or 50, it's pretty hard for things other than prostate cancer to create that kind of elevation. If the PSA is less than 20, we can't be as certain whether we're dealing with prostate cancer or not. That's why you need the results of a digital rectal exam and the results of the biopsy.
How far is the results on a Gleason score of 3+4 as opposed to 4+3, and relate that to Gleason score of 6?
Well, a Gleason 6 would have to be a 3+3. Yeah. So if you've got 3+4 or 4+3, you're not a low risk prostate cancer. That puts you into the intermediate risk category.
But if you're into if your Gleason score is 3+4, you're lower risk than 4+3.
That's right. That's right. The first number is a reflection of the most common pattern of disease that the pathologist sees when they look at the prostate cancer biopsies under the microscope. And the second number is the second most common pattern of disease that they see. So that's why a Gleason 3+4 is not the same as a 4+3. A Gleason 3 is less aggressive looking cancer than a 4.
And being it's a human thing, there has to be a margin of error.
Yep. There's a margin of error in the sense that biopsies only sample. It's not taking the whole prostate out and looking at it, so biopsies can miss. And there's a margin for error in terms of the pathologist.
Could it be actually more serious, or could it be less serious?
Yes, potentially. Most of the time the concern is, could it be more serious? And we know that if a man has his prostate cancer removed, has surgery, then about 20-25% of the time we actually see an upstaging in terms of the score. So cancer that was a 3+3 might actually be a 3+4 when you look at the whole prostate gland. So biopsies are a sample. They can't tell you definitively what's going on in the whole gland. The only way to know that is to take out the whole gland and look at it under the microscope. We distinguish 3+4 from 4+3 because many centers will offer brachytherapy, which is the seed implantation with radiation, for Gleason 3+4 cancer, but they're not comfortable offering that kind of treatment to a man with Gleason 4+3. So it is an important distinction. I think there was another question.
7 out of 10 cores come back positive, and 25% of the gland is cancerous. What category would that put you in?
Well, so I need to know the Gleason score, yeah, and still need to know the PSA and the way. 7.7. Okay, and so. So I can't give you an answer. To determine risk category, you need the Gleason score, you need the size of the gland and an assessment of the way the gland feels, and you need the PSA.
What if you're in the intermediate risk? Can you opt for active surveillance?
I think it's an option worthy of discussion. I think many doctors would be more uncomfortable putting that man on an active surveillance program, but I think it also depends on whether there are other health problems that are more likely to be a threat to that man's life. So if you are a man with a Gleason 3+4 cancer who has a good chance of living another 20 years, I think most of us would be uncomfortable offering active surveillance to that man. If you are a man with a Gleason 3+4 cancer who's had 2 heart attacks and a stroke and has poorly controlled diabetes and is much more likely to run into significant problems with your health related to those problems, then we might be very comfortable surveying that patient. So it's never a decision that's made on the basis of what we know about the prostate cancer alone. It has to be made in the context of, is this the right choice for this patient? And that's it. Well, I think that's you and your doctor. I mean, you're the one who has to take the treatment. You're the one who has to agree not to go on treatment if that option is presented to you. And we know that about half the men who go on active surveillance programs actually end up coming off of it of their own choosing over time. They recognize that I thought I'd be comfortable just watching this, but I'm losing sleep over it, I'm worrying about what's happening, or I'm not worrying about it very much, but my wife is sure on my case about the fact that I'm not doing anything about this. So about half the men who go on to surveillance programs actually choose to come off of it over time, not because things have changed in what we understand about their cancer. Their Gleason score is the same, the PSA is the same, the gland doesn't feel differently, but they recognize over time that they would just as soon get something done about it. And they may be less concerned over time about the potential risks of prostate cancer treatment, the impact that that can have on sexual function and on bladder control.
When you go for PSA test, they always ask, also pick up the testosterone. What's that got to do with it?
Take what, sorry? Testosterone? Yeah, we tend to use that more in men who are on hormone treatment for prostate cancer. And what we want to know is the hormone treatment suppressing their testosterone? That's how we treat advanced prostate cancer, to start with anyway. And so it's a way of testing whether the hormone treatments that you're on are doing what we want them to do.
If it's low, it's okay, or is high when it's okay?
Well, I guess it depends on your perspective. What we want to see is that the testosterone is low. That means the hormone therapy is doing what we want it to do. Unfortunately, what that causes for men is the side effects that go along with being on hormone treatment. The hot flushes, the tiredness, the loss of a sense of vigor and energy, the effects that can have on sexual function. So from the physician's perspective, we want that testosterone to be low, but that's where the side effects from prostate cancer treatment come from, by suppressing that testosterone.
If you take a cholesterol, a friend of mine, Dr. Gibbon, because he didn't have any, so Dr. Gibbon was cholesterol pills. Is that good or bad?
I'd be very concerned about a man with prostate cancer taking extra testosterone, yes.
Why?
Because of the potential for it to drive the disease. Testosterone stimulates prostate cancer cells. We know that. This is a disease that is driven by male hormone. So taking supplemental male hormone would concern me for the potential to cause problems related to how that man's prostate cancer would behave. Okay. Any other questions before we move on to the next segment? All right, so I'm going to share with you a little bit of what has developed over the last year in terms of the treatment options for advanced prostate cancer. I just mentioned that we know and understand that prostate cancer is driven by male hormone. Male hormone feeds these cells and stimulates their growth and the progression of the disease. And we treat advanced prostate cancer by blocking the stimulating effect of male hormone. So we put men on medication that blocks the effect of male hormone, and that's called androgen deprivation therapy. There's been a lot of debate and discussion over the last several years about doing what we call intermittent androgen deprivation therapy versus continuous androgen deprivation therapy. So for many years, it was standard to put a man on these treatments if his prostate cancer was progressing and no longer something that could be treated with the intention of curing it. We know we can often manage this disease with hormone treatments, but we put men on these treatments and we left them on it indefinitely until we saw signs that the treatment was no longer working. And for men who've been on that kind of treatment, you know the side effects that go along with this. Many men have been on these treatments for many years, and we've had the opportunity to learn from that experience that in doing that, we may cause a higher risk of other health problems, particularly cardiovascular disease, and we know that these treatments have an impact on bone health. They can lead to thinning of the bones, and that can predispose to problems like fractures and other health issues related to poor bone health. So a few years ago, people started looking at using these treatments on an intermittent basis. So using the treatment to drive the PSA down, and when the PSA has hit a low level, then putting the hormone treatments on hold and reinstituting the treatment when the PSA starts to creep up on us again. And the idea being that you would spare men the effect of the androgen deprivation by giving them a break from the treatment. That might help men deal with the side effects. You get a holiday from the drugs, but it might also help to impact the effect we have on cardiovascular and bone health. And we've been trying to refine how we do intermittent androgen deprivation therapy over the last few years. It's used fairly commonly nowadays, although there are many who would say that this is still an experimental way of treating this disease. But in the last year, there have been two important clinical trials, one called NCIC PR7 and PR8. And these were looking at different populations of men, comparing intermittent to continuous androgen deprivation therapy. And what we've learned from those trials is that intermittent androgen deprivation therapy is probably a reasonable option for many men. But again, it's a matter of sitting down with your doctor, looking at your particular set of circumstances in relation to the management of advanced prostate cancer and deciding whether you are a good candidate for intermittent or continuous treatment. So I think an option for men who are being treated for advanced prostate cancer to be aware of. Not all men with advanced prostate cancer are going to be candidates for intermittent therapy. And if you go on an intermittent therapy program, then you're making a commitment to the follow-up that's needed to monitor what's happening with your PSA and your testosterone so that if we see a concern, we can reinstitute the treatment when it's needed. But doing this, men can sometimes get a break from the effects of hormonal therapy for several months, a year, even 2 years before the PSA starts to creep up on us and we have to institute the treatment again. And for many men, that's an advantage they want access to.
How come the PSA goes down 11 pounds just like that?
Well, as I said, if we block male hormone,
I have had no treatments. I had, I call it the remote in 2004, and they said it was cancer. And then when they operated, there was no cancer.
so they may have removed all of it with that initial procedure.
Cancer and what came out of the prostate.
When you had your prostate gland removed?
No, just the inside, you know.
TURP.
Okay, I'm not sure I'm understanding. So you had,
Is that what you call it?
sure, so you had a TURP
Yeah. And
and you were told there was cancer there.
after that, my PSA was still 8. And so then 2 years later, 3 years later, it was 16. And then I had a biopsy, that's when I was 16. And it's been going up, I have the whole graph here. And then it went up to 36, and then one went up to 41, and then all of a sudden it dropped. I haven't had no treatment, none whatsoever.
And have you had that test repeated to confirm that that drop?
Pardon me?
Has the blood test been repeated to confirm that the
No,
PSA has dropped?
This was just done 4 weeks ago.
Yeah, so if you've had no treatment, I'd wonder why that PSA fell, and I'd be a little concerned that maybe there was a mix-up in the lab and your blood test should be rechecked. Because if we don't have a good explanation for why your PSA fell, then we have to ask ourselves if there's a problem with the test.
Because it stayed pretty low on one level, and then it went up to 41, and then all of a sudden it dropped.
Yeah.
And the doc said to me, he said, see you in October 2013.
Yeah.
I should start at the beginning because in 2004, I had trouble going to the washroom, which is a common thing. And that's why the operated didn't go. So then, after they found that, I didn't get no treatments or nothing. Yet my PSA was still 8 after I was operated.
So were you told after that procedure that there was prostate cancer in those specimens?
No, they said there was no cancer.
Okay.
So then anyway, in 2007, they took a biopsy, and it was around 16.
Right.
And they still didn't do anything.
Right, but as I mentioned earlier, sir, PSA is not a specific test for cancer.
Oh, I know that my dad died on it. He suffered for 10 years. My son died at 46, and he only lived for a week. And then my brother in Ontario, he got cancer, and he's gone too.
But just because your PSA is elevated does not mean that you necessarily have prostate cancer.
Anyway, I'm not supposed to go back till October 2013.
If you've had biopsies done,
All they say to me when I come in the Baker Center or in the Holy Cross office, Fred, you're looking good, you know. Yeah, I said, look good, I feel good too, you know.
so if you've been seen at the Baker, there must have been at some point a concern about prostate cancer on the biopsies or the
I was
specimens.
in 3 hospitals a month ago, and I went to 3 different hospitals, I got all the tests, and they couldn't find it.
Yeah, it's hard for me to give you more answers based on the information you've given me, so I don't know what else to tell you.
I got 2 other doctors, and they said, Fred, you were too old to have any operations.
It sounds to me like the problem is being followed, though. You are seeing somebody to follow up on this, correct?
Well, not those particular doctors. I had coffee with them at a restaurant, and that's what they said. I'm going to be 83 on Sunday, so. He said, at your age, he said they wouldn't do anything anymore.
Well, they probably wouldn't do an operation, no. But other options may be reasonable. But the first question is still, do you have prostate cancer? And I'm still not sure whether that's the case.
Why would he give me a year to come back, you know?
Well, clearly your PSA is elevated and they want to follow up on that. They want to make sure they're not missing a problem with cancer.
I don't know. Especially when your whole family is horribly born from prostate cancer, you would think they'd do something about it.
It's definitely a concern, so it needs to be followed up, for sure.
My son at 46, you know, he worked in Detroit, he got a pain on Friday, and I moved down to Detroit, and he was already on life support on Monday.
Okay. Yeah, I think we need to move on, sir. Okay. So I'm going to talk to you now about some of the new drug treatments for advanced prostate cancer, ways that we're refining our ability to manipulate the male hormone environment, some new chemotherapy treatment, and then I'm going to update you a little bit on something I talked to you about last year with a form of treatment we call vaccine therapy. And then, because it's always a very important issue for men with prostate cancer to be aware of, a little bit about bone health and a new treatment that may be relevant there as well. So this is a disease driven by male hormone, and the major source of male hormone in the body is the testicles. And we know that if we block the stimulating effect of male hormone, we can effectively treat an advanced case of prostate cancer more than 85% of the time. The disease will respond to that form of treatment. And those responses can last as short as a few months to as long as many years for some men. When we start to see signs that the disease is not responding as well to blocking male hormone, we can add in other drugs. There's still a little bit of male hormone being produced by the body. It's made in other tissues other than the testicles. And we know even with the ability to block most of the male hormone that's being produced, there's still a small amount there. And we've learned over the years that adding in some of these other drugs, so some of these names may be ones you recognize, biclutamide, flutamide, and nilutamide, we can eliminate the stimulating effect of that small amount of male hormone that remains, and that is effective in about 25% of cases in helping to manage the disease. But our understanding of the importance of male hormone and how it drives this disease has continued to evolve over the last couple of years. And we now recognize that prostate cancer cells themselves can make male hormone to drive their own growth. And new drug treatments are able to target that kind of hormone production within the prostate cancer cell. So there are a couple of new agents that you've probably heard about if you've been reading about this disease or about some of the new treatments. A drug called abiraterone. And that agent blocks one of the enzymes that are very important in the pathway of male hormone production. It's a very well-tolerated drug. It's taken by mouth, and very, very minimal side effects for men who go on this treatment. And we learned from clinical trials done over the last few years that in men with advanced prostate cancer whose cancer is no longer responding to chemotherapy treatment, that using this agent improves the outcomes. Men can live longer with this disease, and they survive with better quality of life and better symptom control. And we now have access to this drug through the cancer program here in Alberta. Studies have been undertaken in men who have not yet had chemotherapy for their prostate cancer. So their disease is not quite as advanced, although they're still dealing with advanced cancer. And just recently, the results of those clinical trials have also shown a benefit in terms of survival, quality of life, and symptom control. And so we don't have access to abiraterone at this point in time for that particular population of patients, but that is something we will be pursuing over the next few months. And when you see the benefits of a drug like this in the most advanced types or forms of the disease, then obviously it leads people to ask the question, if we use this agent earlier in the course of this disease, will it also help to improve outcomes? And so over the next few years, we will see clinical trials earlier and earlier in the course of prostate cancer with drugs like abiraterone.
Is it used in also the hormone?
Yes, we maintain the hormone injections, and you add this agent in, and it's taken by mouth. Yeah. The same is true for another drug that's coming down the pipeline, a drug called enzalutamide. This one acts a little differently. This one actually sits on the hormone receptor on the cancer cell and blocks testosterone from stimulating that receptor. And It also appears that this drug may have an important role in a cellular process called apoptosis. Cells are born, they live a period of time, and they die. And they do that in response to following a program that is built into the cell. And we talk about apoptosis is the term we use to describe what we call programmed cell death. So a cell has a normal lifespan, it lives that lifespan of that life, and it dies. In many cancer cells, the mechanisms that are important for apoptosis are abnormal. And so those cells live for a much longer period of time than they would otherwise. And this drug may have the ability to sort of reset that calendar and help to restore the cell's sort of normal lifespan and kill these cells off more quickly than they would otherwise die on their own. Again, this is an orally administered drug, very well tolerated by patients who've taken it on clinical trials, and I think another agent that's going to have a significant impact here on how we manage advanced disease. So there are two clinical trials, one called AFFIRM and one called PREVAIL. The AFFIRM trial in patients who have advanced prostate cancer who've already received chemotherapy treatment for their disease has now reported results. And the benefits were of sufficient magnitude that the trial was actually stopped early at what we call an interim analysis. There was enough of a sign of a benefit associated with this drug that the what we call Safety Data Monitoring Committee, who was monitoring the results of the trial, said you have to stop at this point. We're seeing enough of a benefit in men who are on the active arm of the study that it's not ethically right to continue to randomize men on the two arms of this study, and you need to unblind the trial and give the men who've been on the placebo arm of the trial the opportunity to receive the active drug. So there was a significant benefit there. There are also clinical trials in the pre-chemotherapy setting here. That's the PREVAIL study. All of the patients have been registered onto that trial, and the follow-up is ongoing right now, and we hope to see results from this study over the next couple of years. So I think these two agents represent a significant advancement in terms of our ability to manage advanced prostate cancer, and disease that we used to think of as becoming resistant to hormone treatment is actually responding to better ways of manipulating the male hormone environment. And I think the other thing that's exciting about these drugs is that when a man is dealing with advanced prostate cancer and that treatment is no longer, or that disease is no longer responding to our traditional ways of manipulating the hormone environment, then often our next option is chemotherapy treatment. And that's not a viable option for all men with advanced prostate cancer. That's difficult treatment, and some men are not well enough to receive that kind of treatment. These drugs are very well tolerated and very easy to give, even in men who are not in the best health. And so I think one of the things that is exciting here is that this is going to open up another option for treatment, even for men who are not necessarily of sufficient health that they would be able to go on to chemotherapy treatment. So with these new drugs, there will be many more clinical trials looking at the potential benefits of these drugs earlier in the course of the disease, or in combination with our other treatments like radiation therapy or as adjuncts to surgery, and that's going to create more opportunities for our patients.
Excuse me, are those drugs available for everyone right now, or is it just clinical trials?
So abiraterone is available and funded in Alberta for men whose prostate cancer is no longer responding to chemotherapy treatment. It is not funded as yet for men who have not had chemotherapy treatment, and enzalutamide is not funded for either one of those indications yet. Those indications for funding will be pursued over the next year or so, and so I think that we will see these becoming available over the next year or two. But right now, the only one that is available is abiraterone in men whose disease is no longer responding to chemotherapy.
Dr. Ruether, one quick question. If you're between 65 and 75, you have cancer, but it's in your prostate only, you've got biopsies to prove all that. Why don't we just take it out? You going to be celibate, but I haven't heard you mention that. I mean, instead of going under radiation and chemo and et cetera.
Well, we wouldn't use chemotherapy for early disease. For men with early disease, you have the options of looking at surgery, external beam radiation therapy, brachytherapy, which this is seed implantation of radiation, or a form of treatment called cryotherapy. Not all of those treatment options are necessarily good choices for all patients, so you'd need to sit down and have a conversation with your doctor about what are the appropriate options for me to look at. But that is a situation that is potentially curable if it's confined to the prostate cancer. But as I mentioned to you earlier, one of the questions we still struggle with is we don't know necessarily that a man with localized prostate cancer is going to die of that disease, even if we do nothing. And so for many men, I think the option of watching this as long as it's being monitored closely is a reasonable choice. But certainly if you've got localized disease, you're a candidate for curative intent treatment, and all of the local therapy options are equally effective in terms of the potential to control your cancer in the long term. So there's no data to tell us that surgery is better than external beam radiation therapy, is better than brachytherapy. They're all equally comparable in the right circumstances.
Now, just because the government isn't funding these drugs to all patients, does that automatically mean they aren't worth pursuing in other venues, or?
Well, if you have private insurance, that might provide coverage. They are very expensive. They cost between $5,000 and $6,000 a month. So for most people, that's not manageable if you don't have private insurance. And many of us don't. So it is certainly is a conversation I've had with a few patients over the last while. Most of the private insurers haven't picked this up yet, but I think we'll see that over the next year or so as well. I think I saw another hand go up somewhere.
I'd just like to ask, at what point do you call the cancer advanced?
So we talk about locally advanced disease. So that's disease that is producing an abnormality that we can feel in the gland, or if it's extended into important structures around the prostate, it's called the seminal vesicles, that would be locally advanced cancer. When we talk about advanced cancer, we also potentially are talking about what we call metastatic disease, so disease that has spread to lymph nodes in the abdomen or to other parts of the body, most commonly the bones with prostate cancer.
Do you have the number for the Gleason score at that point?
Gleason score doesn't necessarily relate. So you can have a Gleason 6 cancer that is advanced if there's a large volume of it, or if it's spread to other parts of the body. You could have a Gleason 8 cancer that is confined to the prostate gland. That's still a localized cancer. So the Gleason score and the extent of the disease don't necessarily, one does not necessarily correlate with the other.
Okay, thanks.
Okay.
Dr. Ruether, your presentation has been very informative, especially for me, and I was wondering if you have are you going to give us a handout, that information?
I didn't bring handouts with me, but I'm happy to provide to the Prostate Cancer Canada Network copies of the slide set, and they could make paper copies of the presentation for you. Yeah.
It's also captured on video.
And it's captured on the video, that's right.
This will be on our website. You can review it at home.
I guess I find the information so valuable. I'm anticipating my next visit with my oncologist and having a more productive discussion with him.
Well, good. I hope it helped. I hope he thanks me too. I suspect not. So there is another new drug coming down the pipeline, which we call TAC 700. Only recently have they given it a name. This is a medication very similar to abiraterone, but it targets more than one enzyme in the pathway that is important in androgen production. And as is true for abiraterone and enzalutamide, it is going through clinical research trials right now in advanced forms of prostate cancer. I anticipate we will see positive results with these trials as well, and then that drug will also move into earlier testing in earlier stages of the disease. And in the next few months, we hope to have a trial that combines radiation therapy with this agent. It's not open yet, but it's coming soon. So I've talked to you about improvements in the management of hormone treatment for prostate cancer and our ability to manage the hormone environment. For men whose disease is no longer sensitive to hormone treatments, we often use a treatment with a drug called docetaxel. That is a chemotherapy drug that's given by an intravenous injection once every 3 weeks. Usually a pretty well-tolerated treatment, but it can cause nausea, fatigue, hair loss, causes an increased risk of infection, and not all men who receive this treatment benefit from it. It is the only chemotherapy drug that has ever been shown in clinical trials to have the kinds of outcomes that we look for in terms of the potential to improve a man's survival with his disease, but also help to control his disease and the symptoms that his cancer is causing for him. But there's now a new chemotherapy drug, and it's kind of a cousin to docetaxel called cabazitaxel. It's kind of docetaxel on steroids. So a more potent drug for sure, and in men from a clinical trial, in men whose disease has been treated with docetaxel, they looked at this drug in comparison to an older chemotherapy agent called mitoxantrone, and indeed we saw improvements in survival and disease and symptom control. But this is challenging treatment. It's more difficult for patients to receive than the docetaxel, higher risk of problems with infections, and more likely to cause side effects that patients struggle to deal with while they're on this treatment. So it's not a treatment for everybody, but it does create another option for us for patients whose disease is not responding to docetaxel anymore. And we now have access to this agent also in Alberta. It's called Jevtana. And so we can use this drug in the appropriate patients whose disease is no longer responding to treatment with docetaxel. And when we see those kinds of benefits, then it leads people to ask the next question. Maybe this is better than the chemotherapy drug we have access to right now and use. And so there is a clinical trial right now comparing these two forms of chemotherapy. Results from that will probably be available over the next couple of years. Now, last year I talked to you about a form of treatment called Provenge or Sipuleucel T, and it gets a lot of press. We get asked a lot about this when patients come up to the cancer clinic. What happens with this treatment is that we extract what are called dendritic cells from the patient. So you have a large intravenous put in your arm, and your blood comes out and runs through a machine, kind of like a dialysis machine. And we can skim off this population of cells that we want to harvest. And then those cells are grown up in a culture, and we teach them, in a way, how to recognize a certain marker that is found on prostate cancer cells. And then we give those cells back to the patient. And last year, when I presented to this group, I told you that there was a study of over 500 patients that showed that this kind of treatment was associated with improvements, similar to what I've talked to you about with the other treatments we've talked about here, improvements in survival and symptom control. Unfortunately, those results have not been borne out. And recently there have been people much smarter than me who have looked at the results of these trials and have actually leveled very valid criticisms against the trial and said one of the reasons this treatment may look better is that the men in the control arm didn't do as well as they should have. And so maybe the apparent benefit is because your control subjects didn't do as well as they should with their cancer. So I bring this up because, number one, we get asked a lot about this because it isn't something that is available in Canada as yet. And it demonstrates the fact that when we do these kinds of research trials, it's very important that we follow up on those initial results. We see something we're excited about and it looks like a step in the right direction. It's important to follow up and ensure that those results are borne out over time. And sometimes we see that they're not. So it's a disappointment that this is the outcome, but it is, I guess, reassuring that we're not missing out on something here in Canada by not having access to this treatment. I'm very comfortable that this is not a blockbuster that our patients are missing out on because it's not available here in Canada. And I think it's very questionable as to whether this will ever be made available to patients in Canada based on these results. Now, I'm just going to finish up a little bit with discussions about issues related to bone health. I'm sure many of you know that when prostate cancer spreads to other parts of the body, one of the most common sites of the body that is affected is the bones. So prostate cancer is bad for your bones. The hormone treatment that we use to manage prostate cancer is hard on your bones. It causes thinning of the bones and leads to problems with osteoporosis. And we recognize that that's a common problem in men who are dealing with a diagnosis of prostate cancer. So it's very important for men with prostate cancer to be aware of the things that they can be doing to help look after their bones. And that's ensuring you're getting enough calcium, 1,500 milligrams a day. Most of us as adults are not big dairy consumers, and so we probably don't get enough calcium in our diet. The other thing that's important for bone health is vitamin D. And living in this part of the world, we don't see enough of the sun on a regular basis to make adequate levels of vitamin D. And vitamin D deficiency is such a significant problem in the Canadian population that there are now recommendations that you don't even have to measure the vitamin D levels. Pretty much all of us as adults should be taking some supplemental vitamin D, probably somewhere between 800 and 2,000 units a day. The other thing you can do to help look after your bones is quit smoking. Smoking is hard on your bones, it thins your bones. And then the last thing is weight-bearing exercise. So walking for the lower body, some lightweight training for upper body, those things are good in helping to preserve bone density. So for a man with prostate cancer, these are important things to be aware of.
Some curiosity, does swimming constitute weight bearing?
Not really, because you're not putting a lot of weight across the joints. The good thing about swimming is it doesn't put pressure on the joints, so it's good cardiovascular exercise, and probably any form of exercise is going to provide some benefit. But weight-bearing exercise is what's really good for the bones. You don't have to be putting a lot of stress across your joints. You don't have to be making yourself hurt. So that's why I say walking for the lower body, lightweight training for upper body. You don't have to compete with the weightlifters, but putting a bit of extra weight across the joints is very helpful in terms of preserving bone density. But certainly swimming is an excellent form of exercise in terms of cardiovascular health.
What I was thinking of was because of the resistance that it has.
Yeah, probably not quite as much resistance as you're looking for. Yeah.
Did you mention vitamin B or D?
D.
D.
Vitamin D. Yeah.
Question concerning calcium supplementation.
Yeah.
I've read some material that questions whether or not the absorption of calcium from supplements is as effective. You know, you consume, the body will not consume more than 500 milligrams, so if you're taking dosages over that, it just
may not be getting the benefit from it.
The other thing is some of the negative side effects, development of kidney stones, potential. What are your views in terms of calcium supplementation?
So and there's another concern that's been raised recently that supplemental calcium may increase the risk for cardiovascular problems. That's debated. I think what this is telling us is that the best way to ensure you're getting enough calcium is make sure you're getting it in your diet. So, sorry? There's calcium there for sure, so it's a good way of adding some calcium to the diet. Yeah. So the best way to ensure that you're getting adequate calcium is make sure that your diet is good. But if your diet is not good, then I think taking some additional calcium, you have to weigh the risks and benefits. And so what I tell my patients is, if you are going to consider taking supplemental calcium, I want you to talk to your family doctor about whether that's an advisable thing for you to do or not in terms of risks of cardiovascular disease.
Just a quick follow-up. Can you take too much can you have too much calcium? In other words, if you've got some in your diet, I mean, how many of us calculate how much calcium we're getting by, how much milk, cheese, etc.? Is there a danger of consuming too much calcium on a regular basis?
You'd have to take a lot of extra calcium to cause problems, but yes, there is a concern. It could increase your risk of problems with kidney stones.
Excessive.
You'd have to be taking 8, 9, 10 times this dose. So you probably wouldn't poop for about 3 months if you're taking that amount of calcium. So you'd have concerns long before you'd worry about, So I think it's important to be aware of the importance of calcium. The best thing to do is make sure that your diet is adequate, but if you have challenges with your diet, talk to your family doctor about whether a calcium supplement is advisable. But vitamin D supplementation, very safe and recommended for most of us as adults now. If you've been diagnosed with osteoporosis, you may recognize the name of some of these drugs, Didrical, Fosamax, Zometa. Those are drugs that can be used to help manage problems with thinning of the bones if calcium, vitamin D, and weight-bearing exercise aren't sufficient to look after the problems. And there's a new drug called Xgeva, works differently than the drugs I've listed there, what are called the bisphosphonates. And it is also showing benefits, both in the treatment of osteoporosis, but also in the management of advanced prostate cancer that is affecting bones. Now I've got... So this is just to show you that in healthy bone, there's a constant process that helps to keep bones healthy and active. So there are cells called osteoclasts that break down old bone. And these produce a chemical called rank ligand that then stimulate, it's osteoblasts, the cells that make bone, produce rank ligand, and that chemical stimulates what are called osteoclasts, the cells that break down bone. So there's this constant balance between cells that are forming new bone and maintaining bone health, and the cells that are breaking down old bone. As we get older, the balance gets tipped more in favor of the cells that are destroying bone. And that's why we all experience some thinning of our bone as we get older. So this process is going on at all times, and up to about the age of 30, 35, the balance is in favor of building bone. After that age, the tips in favor in the opposite direction. And we understand now that that same molecule, rank ligand, actually can stimulate cancer cells that are in the bone and cause them to destroy bone. So this new drug, denosumab, actually blocks that messenger and helps to prevent the reabsorption of older bone, and that helps to maintain bone integrity. And so this drug has a role to play in the management of osteoporosis, but it also has potentially benefits in men whose prostate cancer is affecting their bones. Now, access to these agents, these are the two that have been shown to have the most benefit in men with prostate cancer, is problematic in Alberta right now. In Calgary, we can access Zometa through a complicated process. We cannot access denosumab outside of private insurance covering it, and most patients don't have private insurance that would cover it. In the rest of the province, neither of these agents are easily accessible, and we are doing things with, in dealing with Alberta Health Services to try and address this disparity, because I think men with prostate cancer need access to these agents to help manage problems with their bones. So I hope what I've shown you tonight is that every year we see improvements in the outcomes for men who are dealing with prostate cancer, and that comes out of our growing understanding of how this disease grows and affects men, but also out of the willingness of patients like you to participate in clinical research trials that allow us to test what we learn and to test these new treatments. And that's how we improve the care of patients with any type of cancer, is through clinical research trials. So if you are approached at any time by your doctors about the potential to be involved in a clinical study, I'd encourage you to read that information very carefully. Thank you.